Hello, everyone. Welcome to
All right.
I'm Omid Moghaddas from Tehran, and again, very grateful and happy to join you all from this platform, this educational platform. And I have a very special guest and a very good friend of mine. Ziv Mazor is here with us today from Israel, and I have to say that having such legends and iconic practitioners and educators in the program is very valuable for all of us to learn from the best. And I'm pretty sure most of you are familiar with his famous phrase, thinking out of the box. And I'm pretty sure you will see lots of those thinking during his presentation. Ziv, hello and welcome to Hot Seat.
Hello. Happy to see you, Omid.
Thanks so much, my friend. As a tradition, I will have a Ziv CV for all of you. I'm pretty sure most of you know this amazing educator, but I will have a brief introduction of dear Ziv Mazor. He's one of the Israelis' leading periodontists. He graduated from the periodontal department at the Hadassah School for Dental Medicine in Jerusalem, where he served as a clinical instructor and lecturer for undergraduate and postgraduate dental students. Since 1993, he's been engaged in clinical research in the field of bone augmentation and sinus floor elevation. He is currently participating in the quest for improving and evaluating new grafting materials using various growth factors, as well as researching osteodensification, a paradigm shift in dental implantology. Professor Ziv Mazor is a renowned author in dental implantology and is known worldwide for his innovative approaches in cutting-edge procedures and technologies. He is a world-known speaker and has lectured extensively both nationally and internationally. This year was his 25th consecutive year speaking at American Academy of Periodontology. Professor Mazor is part of continuing education faculty at the New York University and an associate professor in Taitu, if I pronounce it good, Mărescu University, Bucharest, Romania. He conducts and moderates advanced international odontology courses and workshops. He is the past president of Israeli Periodontal Society and has a private practice limited to periodontal and implant dentistry in Tel Aviv. Once again, so thankful and appreciate your accepting the invitation, and really looking forward to hear your amazing presentation on maxillary sinus complications, how to prevent and how to treat. The platform is all yours.
So it gives me a great pleasure to share with you today one of my favorite topics over the years, which is dealing with sinus augmentation complications. Now, some of the data and principles that I will be showing you today is based not on reading the literature, but basically based on management of complications that I encountered during my years in private practice. And sometimes you have to learn from your mistakes in order not to repeat them afterwards. And today I will try to share with you some of those mistakes and how we can prevent them before they happen. So, starting first, my initial career when I started to do sinuses. Here you can see a case that I've done more than 20 years ago. And at that time, we needed to perform the procedure which was called sinus elevation or augmentation. And that was via the lateral window technique. So basically what we have done in those years is we created a big lateral window in the lateral aspect of the maxilla. by using all kinds of instrumentation. And then we lifted up the membrane, providing it was intact, we applied our biomaterial. And you can see here the biomaterial that we were using more than 20 years ago. And by the way, it is still used very extensively over the world. Covered the lateral window with a resorbable collagen membrane, waited for about 9 months, and then we came back in, inserted our implants, wait additional 6 months for implant integration, and afterwards we were able to fabricate the final prosthesis. Here is the case I showed you 21 years later. And 21 years later, we see the outcome of this treatment modality, which is long-lasting treatment procedure. When we check the combing CT before the treatment, 9 months post, and 21-year post, you can see on the screen that the outcome of the procedure is very favorable and long-lasting. So, what are the complications which are associated with augmentation of the maxillary sinus? We can divide it into 3 groups: poor patient selection and diagnosis, poor surgical technique, and poor patient management. So let's start with poor patient selection and diagnosis. So when we talk about patient selection, of course, we have to understand that there are some patients which are not suitable for doing that type of procedure. Not just for sinus elevation, but even for conventional implant placement. So a patient which has uncontrolled diabetes, of course, is not a suitable patient to run the procedure. Patients which had high radiation to the head and neck, of course, are not favorable patients to do sinus augmentation. But other than that, we have some localized contraindications. The first one is acute sinusitis. So patients which need sinus augmentation and come to our office, and you see on the right-hand side that the sinus is full with some kind of a liquid, and that is because they suffer from acute sinusitis, we first have to take care of this medical condition before we try to attempt and do our sinus elevation. Here is another example. A patient that comes to my office, she needs a sinus augmentation in the upper left segment. And again, you can see how much of fluid is present in the maxillary sinus. Now, if I ask you, how do you differentiate between acute sinusitis and another pathology like thickened membrane or polyp, just according to those CBCTs? Well, the answer is very clear. If you see that the level here is horizontal, that means that there is some kind of a fluid in the sinus, and that is not a polyp or any other pathology. Maxillary cysts and tumors. So here you can see the difference between what you've seen before and this kind of polyp, which is present, or cyst, which is present inside the sinus. How are we going to deal with that kind of pathology? What is the real problem by applying our lateral window while we have this pathology? Well, the only problem is not the cyst. The problem is that when you lift everything up, you might block the ostium. And if you block the ostium, that might lead to severe complications. So there are many ways how to get rid of those cysts, like you see here. One of the outside the box procedures that I extremely like is called the croco eye procedure that I will show you just in a few seconds. But here you can see a patient that had bilateral huge cysts. Now imagine that if we want to elevate the sinus here, we would block the ostium for sure. So we have first to take those pathologies out. How do we do it? We first reflect the lateral aspect of the maxilla. We perform the oval window, and then with a syringe, we are aspirating the cyst. After aspirating the cyst, we take a small blade and we do a small cut in the membrane. And then we are able, with some delicate mosquitoes, to take the cyst out. And you can see on the bottom how we were able to take the entire cyst out. Here is the other side. Again, you can see the shape and the design that I did for the lateral window. And then I took my syringe, aspirated the cyst, then made a very small cut. And you can see the cut in the membrane. And that is called the croco-eye procedure. Why? Because it resembles the eye of the crocodile. And that concept was developed together with my very good friend from Wrocław, Poland, Radosław Jada. So then, after taking the cyst out, we take a PRF membrane, we seal the perforation that was deliberately done by us, and then we can continue and fill up the sinus cavity space, place our biomaterials, and here is the radiographic appearance of that particular case right after we augmented both sinuses. And of course, later on, you can see here the post-op CBCT, the X-ray that was taken after placing the implants in the grafted sinus, and of course, the case is completed. Here is another example, a big cyst. And again, here you can see what is the cause of the pathology, because you see a periapical lesion around the premolar. Now, you have to understand that you cannot perform sinus augmentation if you have pathologies present in the area. So if you have a periapical lesion of an adjacent tooth, first you have to get rid of that infection. Otherwise, you would perform your sinus, and even if you are the smartest and the most skilled surgeon in the world, and you will perform the sinus, you will get infection later on. And everything is just because of your stupidity that you didn't take that tooth out before. So again, you can see nicely here the cyst, which is present here. And we are now doing a window, making a small cut. And here you can see that, not deliberately, but there are also two minor little perforations here in the membrane. So that resembles to me like the mask of Halloween. But again, we take the cyst out. You can see nicely here how I reflect the cyst. And then we seal the perforation with a membrane here, placing our graft material. And you can see that after sealing the perforation, how the movement of the membrane continues. Other localized contraindications are presence of oroantral fistula. Now, if you have a patient that has an oroantral fistula, like you see here on the right-hand side, it's a contraindication to do sinus augmentation. You have first to get rid and close the fistula, and only later on you can think about doing sinus elevation. Root tips and foreign bodies which are in the sinus. So here you can see a typical example. On the right-hand side, you can see some remnants of biomaterial, probably due to root canal therapy, that were left and inside the maxillary sinus, and you can see what that causes to the Schneiderian membrane. So you see a big thickening of the membrane. Here you see some other foreign bodies which are floating in the sinus. And you can see all kinds of dental implants, like helicopters, floating in the sinus. Here are some more examples. I mean, I call that picture the sinus as a dental depot, because, I mean, you buy a lot of implants from your implant manufacturers, but you cannot really utilize those implants. Now, you have to be very skilled to place two implants so parallel to one another inside the maxillary sinus. So as you can see, I have quite a lot of collections of pictures. And take a look here. How can you possibly place implants one on top of the other? You really have to be very, very skilled. So it happens. And of course, I get, from time to time, I get phone calls from colleagues of mine asking me to help them by taking out an implant that was pushed into the sinus. So here you can see one particular case that came, and I did a CBCT right before, and you see where the implant stays here. The implant stays here right where the ostium is. So if you take a 3D software and you analyze where the implant is, you can see that it's right here at the ostium. And of course, the ostium is too narrow for that implant to come out. Another option to take the implant out is by doing endoscopy. So here you can see a nice picture taken from a video from an endoscope. And that is how the ENT takes out those implants. And you can even see here remnants of that crappy biomaterial that was pushed inside. The other localized contraindication is a very thin or inadequate ridge. So if you have a very, very thin ridge, forget about placing an implant simultaneously with sinus augmentation. I mean, there is no problem of doing sinus augmentation and doing some GBR, but don't place your implant at the same time. Now, what about Schneiderian membrane thickening? When should we refer the patient to an ENT consultation? And that's a big question that I'm being asked in all my presentations and courses. So the problem is that if perforation occurs in the presence of a blocked maxillary sinus, the risk of developing chronic sinusitis is significantly higher. So we need to have a patent ostium, like on the upper slide, and not an obstructed one. And that's a key factor for success. A very nice study that was done here in Israel a few years back compared 5 different appearances of sinuses before doing sinus augmentation. So you can see here that the sinus was divided into normal appearance, rounded pathology, irregular pathology, circumferential, and complete obstruction. And the conclusions from that study were that in the presence of the following, it is recommended to refer to an ENT. If we have irregular appearance of more than 5 millimeters, if we have a circumferential appearance or complete obstruction. And it is recommended to expand the dental CT to include the entire maxillary sinus outflow. That means that if you get all kinds of cuts that are in the middle of the sinus, that is not the right CBCT that you should evaluate. So if you are not doing the CBCT by yourselves, ask the radiologist to take a complete picture of the entire maxillary sinus. That was the study that was published in 2011. antral computerized tomography, preoperative evaluation, relationship between mucosal thickening and maxillary sinus function. Now, if we do have those pathologies, how can we clear the sinus? One option is to do what we call functional endoscopic sinus surgery, FES, which is mostly done by the ENT. And there is also a maxillofacial approach by doing a big window like a Caldwell loop procedure. And here you can see how the FES procedure is being utilized to take a huge pathology and cyst out of the maxillary sinus. Of course, it's through the uncinate process from the nose, and here you can see how the cyst was taken out. So we talked about poor patient selection and diagnosis. Let's talk a little bit about poor surgical technique. So here is a case that came for consultation. The patient brought the pre-op CBCT, so I can look at what had been done here. And when she brought her present situation, it looked like that. So what do we actually see? We see that both sinuses are obliterated by a mess of some biomaterial. And if you take a close look, you can even see what the problem was. That clinician did a lateral window, he had a big perforation, and he kept on stuffing biomaterial inside. So he stuffed 1, 2, probably 3 bottles, and then he closed up, and that's what happened. Now, the problem here is that there is no way that this mess of material can be cleared through the ostium. So in order to resolve the problem here, there is no other way but opening up and taking everything out. Here is another example of a perforation that had been done here. And you can see here beautifully the physiology of the maxillary sinus, because you can see how those particles are shifting up towards the ostium, and they will be cleared through the ostium. Poor patient compliance. Now, one of the problems when we do sinuses, especially for edentulous patients, is the pressure of their prosthesis. So if you need to do sinus augmentation for patients with dentures, keep in mind to find some alternative reconstructions. For example, using temporary or mini implants to construct a fixed restoration, or do immediate loading and use the maxillary tuberosity or pterygoids to encourage your implants. Second problem with patient compliance is inappropriate compliance with the antibiotic regimen. Patient has to be prescribed with antibiotics, anti-inflammatory, and you have to understand that you have to pick up the right medication for the patient. I will tell you just a small example. Whenever I do courses and I ask my students, what is the best antibiotic to use when patients are allergic to penicillin? And 95% of the time, I hear the word clindamycin. Well, my friends, that is the worst antibiotics to use in maxillary sinus augmentation. I can tell you that most of my complications were in patients that took clindamycin. So you have to prescribe them with other antibiotics. Inappropriate oral hygiene regimen. Patients after sinus augmentation have to maintain oral hygiene. So we give them rinses. And again, when I ask what is the best rinse to use after maxillary sinus augmentation, and everybody says, well, chlorhexidine. No way, because chlorhexidine slows the healing because it doesn't differentiate between normal cell and a bacterial cell. So you have to think always before you do. Now let's talk about intraoperative complications, which are associated with sinus augmentation. We can talk about early complications and late complications. Let's start with bleeding first. So what's the story with bleeding? If we look at the literature, we see that bleeding is not a major complication. It happens only in 2% of the time. But my friends, believe me, when it happens to you, even in 2%, you will not forget it. What's the problem in bleeding? Only one problem. When it starts, you can hardly see what you do. And when you don't see what you do, then you start to do mistakes. That is the main issue. And in order to prevent bleeding, you have to understand anatomy. And you have to exactly figure out where the blood vessel is before you start to do your osteotomy and your window approach. And you have to understand and appreciate what to do once you hit this blood vessel and how you stop the bleeding. So here you can see on a CBCT the indentation of the blood vessel, the posterior superior alveolar artery. But you will not find it in 100% of the time. Why? Because at least in 20% of the time, the blood vessel runs in the soft tissues. So you don't see it on the CBCT. So you have to be prepared. The blood vessel can be a profound big one, up to, like here, almost 3 millimeters. And believe me, when you hit that type of blood vessel, it bleeds. Sometimes it's visible on the lateral window. And here you can see nicely the blood vessel that runs from anterior to posterior. So, some tips for prevention of intraoperative bleeding. Obtain preoperative CT to locate the vessel. Visualize the vessel in the lateral wall clinically, like you see here. Avoid vessel when designing the window. Use instrumentation that would reduce the risk of hitting those blood vessels, like piezo devices or DASC, and have materials on hand to control the bleeding. So how do you control the bleeding? The best way is to apply pressure with a gauze for several minutes. You need to have patience. It will stop. You can also use bone wax. You can crush the bone channel with a hemostat. You can try and suture the vessel, but I can tell you that in most situations you will not be able to do so, because once the blood vessel is cut, it retracts back, and it will be very difficult to find it. And you can also use electrocautery. So here you can see a nice situation here. So sometimes it's like a fountain. And believe me, when that happens, you have to warn your assistant in the other side of the room, because it goes from one side to the other. Here is a nice case that we treated during one of my hands-on live surgery courses. So for, of course, learning purposes, we decided to do here bilateral sinuses. And here you can see nicely the big blood vessels that run over there, how we can apply and use piezo right on top of the vessel, and nothing will happen, because it doesn't cut soft tissues. It only works on hard tissues. And now we are able to dissect that blood vessel place the graft material, insert the membrane on the lateral aspect, and place the implant at the same time. Here is another example. A huge sinus. There is a blood vessel here that you have to understand that is running there. And here you can see how I dissected the membrane and the blood vessel, and it shows you how it runs from one side to the other. Now, to understand how that blood vessel network work, easily we can cut that blood vessel in two segments, or in one segment, but we can tie the blood vessel in two segments. So here I'm making one knot on the mesial side and another one on the distal side of that blood vessel. And now we can cut it right in the middle with a scalpel, and you see there is no bleeding. So now you can start and carry on your elevation and procedure, apply your graft material without having the disturbance of a profound bleeding in your way. Membrane perforation. Well, this is the most common complication when doing lateral window sinus augmentation. And you might have small perforations and large perforations. And it happens between 10 and 40% of the time. When do we have 10% and when do we have 40%? Well, I would say the more experienced you are, the less perforations you will get. And what is the problem with perforations? First, there is a possibility for infection, and second, containment of the graft. You can lose the graft if you have a perforation. Now, if we look at the literature, you see that it varies between 11% up to 56%, depending on what type of study was showed. Now, what is the cause that lead to a large membrane tear? First, narrow angles of the sinus. If you have a sinus which is quite narrow and you start to elevate it, you might run into a perforation. Redo cases. If there is a case that already had a sinus perforation and you try to redo the case, in a lot of situations you have another perforation. Extremely thin membranes. Sometimes the membranes are so delicate that just by approaching the membrane, it tears up. And partial or complete loss of alveolar bone in the posterior area can happen as well. And sometimes we open up a case and we see an opening right in front of us. And of course, using inappropriate instrumentation. And I can tell you that knowing the industry and what's out there, I can tell you that at least 50% of the sinus curettes that I see are not suitable to do sinus augmentation. How do we handle those perforations? Well, if you have a small or medium perforation, all you need to do is just patch it with either a collagen membrane or PRF. My preference is to use LPRF. If you have a large tear, we can patch it with a big collagen membrane with PRF and fixate the membrane with some pins, like the Loma Linda pouch that was described many years ago. Now, the Schneider membrane forms the apical and distal walls of a container, and that is the principle of the Loma Linda pouch. Let's take a look at some examples. So here, by the way, you can see a small perf in the membrane. Of course, the best way to deal with the perforation is not to have them. But once you do have a perforation, like here, you can see a double perforation. All you need to do is take a PRF membrane here and seal the perforation in one shot. Then you can move ahead and do your augmentation. We can use a collagen membrane, and here you can see the Loma Linda pouch. How, and there is a big perforation here, how the perforation is sealed with the collagen membrane, which is tacked on the buccal aspect of the lateral wall. Now, perforation is about 11% of the intraoperative complications. So here is an example of a perforation. You can see the bubbles coming out. You can see different types of perforations. They can be, it's like going to McDonald's. It can be large, medium, and big size. So the easiest, of course, when you have a small, medium perforation is to take a PRF membrane and seal the perforation. If it's a little bit bigger, you can use a collagen membrane or do a Loma Linda pouch. And here was a case that a Loma Linda pouch was utilized here with a resorbable collagen membrane. And you can see here the final situation. Here is another one, a huge perforation. Again, I used here a big pouch, a Loma Linda pouch, applied the graft material, and here you can see the before and the after, still with the pins that are holding the membrane. Another way to patch perforations, that's a maxillofacial way, is to use titanium mesh together with a PRF or collagen membrane. Of course, every profession does what he feels most comfortable. So here is a typical case that I brought to you, a case of mine that came to do complete reconstruction of the maxilla. And you can note and appreciate that we are talking here of a very resolved ridge, both anterior and posterior. So what I was planning to do here is to do bilateral sinus augmentations, anterior reconstruction, and of course implants to give the patient a fixed restoration. So when I started to do the sinus on the right-hand side, I had a small perforation, which I took a collagen membrane and did like a Loma Linda pouch, placed the graft material inside, and then went to the other side. On the other side, I did a window, and just by doing the window, I could see in front of my eyes how those perforations are starting to get bigger and bigger, and I ended up with a complete perforation of the membrane, which was very, very thin and delicate. So I did a Loma Linda pouch, fixated it to the buccal aspect, and placed my graft material. And here you can see the pre and post-op CBCTs. On the left is the pre-op, on the right is the post-op. And again, here we had a medium perforation that we sealed with a membrane, and everything turned to be very nice. On the other side, where we had a huge perforation, you can see that's the before, this is the after. It's still undergoing now remodeling. Here is the case post-operatively with the implants placed. You can see the pre and post-op CBCTs, right side and left side. You can actually still see the pin that held the membrane here. And here it is on the right, on the bottom, that is a CBCT that was taken 5 years later. with the final prosthesis. Another intraoperative complication is septas. Now, if you ask yourself, what is the prevalence of septas in the maxillary sinus? Believe it or not, 66%. Now, how come we don't see most of those septas when we take a periapical X-ray, a panoramic X-ray, and sometimes on the CBCT, you are not really finding those septas? That is because you don't ask for the right view. If you ask for the sagittal views, you would see a lot of septas which are present in the instance like you see right here. So here are some examples of septas that you can encounter. It can be one septa, it can be more than one septa. Sometimes it's very, very thick, and you can even anchor your implant in that septa. Here again, you can see a huge septa, and that septa, of course, can be utilized to anchor your implants. Postoperative complications. We can talk about hemorrhage and edema. So take a look at those pictures here. Those are not really sexy pictures that you would like to have with your patients. So edema, bruising, hematomas. And take a look at this guy here. Bilateral sinus augmentation. That patient had some liver problems, and he did not notify his surgeon that he has those liver problems, and he had to be hospitalized for 3 days in the hospital because of his situation here. So beware of those problems. Infection. This is what we fear the most, because if you do have this opacity on the left side, couple of weeks after the surgery, you see that the right side looks perfect, the left side doesn't look that way. If you are lucky and you prescribe the right antibiotics and medication, we can get out of it, because you can see how we started on the upper and how we finished on the lower. So we were lucky. But sometimes we are not that lucky. If you take a look at those X-rays, you can see those voids inside the graft material. That can be post-op infection of the graft. And here you can see a typical example of a post-op infection. And that was due to the fact that that clinician decided to place the buccal wall back to its original place. And probably that piece of bone was infected. So if you do want to replace your buccal wall, and you can do it, place it in a sterile Depon dish and cover it up, because you don't want to run into those situations where you have pus coming out where you did your sinus augmentation. And believe me, if you do have pus coming out, don't wait, don't prescribe more medications, open up and take everything out. That was a study we did in 2008, and we got the first prize in that year for articles submitted. And that was an innovative approach that we utilized metronidazole together with the graft material, and we did bilateral cases to see what the difference is. Because sometimes if you take a post-op CBCT, 10 days after the surgery, you get all kinds of spaces here between the graft, and it turns to be that those are bubbles of gas because of the presence of anaerobic bacteria. So the idea was that if we utilize metronidazole, which is effective against anaerobic bacteria, and mix it with our graft material, probably we would be able to prevent this phenomenon. So what we actually did is we did bilateral cases, and you can see here from that study, same patient. On the right side, you see a very nice high-density sinus, which is clear. And on the left, you see low density and sinus opacity. And the right side got metronidazole together with the graft, the other side didn't. So that led us to the assumption that it is very useful to mix our graft material with metronidazole. Now, how should we prevent sinus graft infection? First of all, proper case selection. Remember, I told you absence of sinus pathology according to the CBCT scans. All the local periodontal and endodontic problems have to be eliminated before the surgery. Avoid combined procedures, meaning don't try to be smart and do vertical bone augmentation and sinus augmentation at the same time. Like my friend Dennis Tarnow says, one miracle at a time. Proper prophylactic antibiotics using metronidazole with the graft material. Rinsing and preparing the mouth and face before the surgery. Use sterile draping and infection control protocol, not only in COVID-19 era, but in your everyday sinus procedure. Incision lines should be distant from the window and the barrier membrane. Prevent contamination of saliva and of your graft and membrane. Isolate your instruments and the suction tip that goes into the sinus. And of course, like in every surgery, keep your surgical time as short as possible. And post-operative continuation of the antibiotics and oral hygiene. Now, here is a case that I screwed up, and that was because I was testing a new type of graft material. So you can see here a patient that I treated. It was part of a study of 20 cases that I used hydroxyapatite bone cement. And you can see on the left side how the entire mass of bone dislodged. And the patient comes, and you can see that the entire sinus is obliterated. And I took out the implants together with the surrounding bone graft in one piece. As a matter of fact, I could not take out the graft material out of the implant surface because it was so well integrated to the HA coating implant. Implant migration. Here you can see some typical examples of how on the left-hand side, you can see that that implant shifted in 90 degrees. Why? Because it didn't have enough primary stability. Here is a case. I get a phone call one Friday afternoon from a colleague of mine. Can you bail me out and help me because I was trying to place a healing abutment and my implant got shifted into the sinus. So we take a CBCT and you can see where the implant is. We have to make now a cut in the Schneiderian membrane. And luckily, with a good suction tip, we can take out the implant. Now we seal the perforation with the membrane and everybody's happy. Here is another case of mine that I had a complication. I was testing here another type of graft material, which was a new beta TCP. I did bilateral sinus augmentation here. And you see just 1 month after the procedure, the material starts to resolve very, very quickly, and now the implant starts to shift. So here is the implant now on his way into the maxillary sinus. And of course, I had to open up and take out the implant with, of course, a good suction unit. Here you can see what is the advantage of using a good suction unit. So you need a good suction unit. And here is another video of trying to take out an implant from the maxillary sinus by using the suction tip and the tweezers. And you can see that was done in Korea, how this clinician is trying to get to the implant and retrieve and take it out. But you know, taking only 2D X-ray and trying to get to the implant might be very, very difficult. So you can see the tweezers and almost, but the implant thing's a little bit different, and it starts to run away and go out. So a second attempt. And the implant goes away. So there is the quest in the sinus for the implant, and luckily it was retrieved. So here is another case. Implant dislodged, went inside the sinus. We have to open up, and you can actually see that the entire bony wall is now completely ossified. So you have to redo the lateral window, get to the membrane, and then take the implant out and regraft now the sinus. So sometimes it's quite tricky and not that easy. Late complications. We can talk about graft loss or failure, implant failure, chronic sinus disease, and maxillary cysts and pathologies. Here you can see an infected sinus post-operatively after sinus augmentation had been done. Here again, you can see infection around the implants. So maybe we can save those complications by doing a transcrestal sinus elevation. Will that avoid the complications? Well, we have also intraoperative complications when we do crestal sinus elevation. Sloped sinus floor. If you have a sloped sinus floor and you are trying to do a closed approach, let's say using osteotomes, I can guarantee you almost 100% of the time you will get a perforation. Presence of septas. If you have a septa where you want to do a closed approach and an immediate implant placement, there is no way you can do it. Perforation. You have perforations when you do a crestal approach. There is no way you can patch the perforation and lift up the membrane and place an implant at the same time. Either you close, wait, and come back again, or you shift from a closed to a lateral window approach. Now, what about ridge width? If you have a very narrow ridge, again, it should be a two-step procedure because you have to take first care of the ridge dimensions. And the last complication is when, especially if you use osteotomes, is the development of benign paroxysmal positional vertigo. So those complications are not really complications we would like to have. Now, what happens when we do have those complications? We can, of course, lose the graft due to membrane perforation, but even development of oral-antral communication as a side effect of closed augmentation. And here you can see a typical example. A crestal sinus had been done here, but since there was a perforation, all the graft material was lost. And here is another publication of development of oral-antral communication as an osteotome sinus elevation complication. So you have to take that into consideration. And again, you can see that was done via crestal approach, and someone was having a perforation, and I showed you that particular case before. So one of the options to overcome those complications was using a minimal invasive approach. And that was an approach that I was presenting like 10 years ago when I started to do those minimal invasive approaches. And the idea was to use a balloon device made of silicone, the same angioplasty balloon, but instead of doing a huge lateral window, as you see on the right-hand side, all we needed to do is a very minor, small osteotomy on the crest. Here is an example of one of my screw-ups. A smoker, heavy smoker, lady, 45 years old, came to the office and she needs bilateral sinus augmentation. So I did a lateral window here on the right-hand side. You can note that I had a small perforation that I sealed with a collagen membrane, and I carried on with the procedure, placed implants, bone graft, membrane, PRF. Everything was nice. On the other side, when I just tried to do the window, there was a complete rupture of the membrane, complete. So what do you do in those situations? As I showed you before, we do the Loma Linda pouch. So I did a Loma Linda pouch, placed my graft material, closed it up, took an X-ray, and I was so happy because I thought that I'm the best. So she comes 10 days later with pus coming out and particles which are coming out, and I had no choice but going in and take everything out. Now you look at the patient and you look where the eyeball is, right into the sinus, and you ask yourself, what am I going to do? So here is the right side, fine, and here is the left side. You can actually see where the window was, and we have here about maybe 2 or 3 millimeters of bone height. So I decided here to go for a minimal invasive approach. The 2 anterior implants were done with osteotomes, and the distal implant I did with balloon approach. So I lifted up the membrane from the crest, so I don't need to get even to where I did my initial lateral window. And now I inject the graft material inside and place all those 3 implants at the same time. And that's how it looks right after the surgery. That is how it looks on a post-op CBCT. You can actually see the existing lateral window. And in this picture, which is, to my opinion, the best one, reflecting you the elevation with the balloon and the bone graft that was added on top of that. And that is the reconstruction of the bone on the post-op CBCT. Another way today to overcome those complications is to use what I call the magic, and that is osteodensification. Today, 95% of my sinuses are done that way. And that means that we create more with less. And by using our osteodensifying drills, we always have bone between our osteotomy and the Schneiderian membrane. And that gives us much more precaution. Here is a typical case, an extreme one. I don't advise you when you are beginners to do it in a crestal approach, but that is a patient that had aggressive periodontitis, and she needs extraction also of the second molar and only 2 millimeters of residual bone height. So we go in here, and I'm utilizing the patient's own tooth as my graft material, and that's a subject for a complete lecture. And we do osteodensification now, applying the graft material inside with our burrs, and we get eventually to a position that we can now insert 2 implants with high stability, high insertion torque, wide diameters, with nice sinus floor elevation all around. Here is the post-op CBCT, and 4 months later, we are able to finish up the restoration, and you can see the post-op radiograph with the restoration. Another example, a patient of mine that I did lateral window on the left side some 15 years ago, and now he comes for the right side. And now we go from the crest without doing a lateral window. We do osteodensification, insert the graft material, and place implants at the same time. And take a look at the befores and the afters. So that's a big change of how we started and where we are, with a minimal invasive approach. And here is another one, the last one. Again, you can appreciate that we have maybe 2 millimeters of bone height here. And I decided here not to use any graft material but PRF. So we take PRF and we fill up the space. That was the initial plan. And here is the post-op CBCT, before and after. And another one here, we go to the crest, lift up the sinus with our graft material, insert the implants, and it's a very short procedure, of course, when you are experienced. So unlike lateral window approach, there is no edema or discomfort, and actually patients do not feel almost anything after the procedure. So to make some conclusions, how to avoid sinus lift complications. First, correct diagnosis. CBCT is a must. Right armamentarium, use piezo devices to avoid blood vessel and membrane injuries. Use a material proven to be effective. Don't try a new graft material that has no experience. Use minimal invasive techniques for sinus lift, either balloon approach or osteodensification. And of course, the most important part, experience, experience, and experience. Experience is a hard teacher because she gives the test first and the lesson afterwards. Now, I would like to invite all of you to our teaching facility in Tel Aviv. We opened a branch of the Versa Osteodensification Academy in my institute. We run courses on different subjects throughout the year, and you can actually see here some of the uh, topics that we cover, and we have a very nice faculty together with me. Some of those faculty are really well-known clinicians like Roberto Rossi from Italy, Nelson Pinto from Chile, Samuel Blayen from Moscow, Yanis Vergoulis and Mitzias Militiadis from Greece, Patrick Palacci from France, and many others. So all of you are mostly welcome to come and join us. And I really thank you for your attention. And thank you, Omid, for giving me the opportunity to be in your platform.
Thank you, Ziv. The pleasure is ours, and your presentation was very, very comprehensive on the aspect of complications in the maxillary sinus augmentation. And I'm pretty sure all the audience appreciate what an amazing presentation you gave us during these times. So I have some questions regarding this presentation, and I want to start off with the cases of perforations. Sometimes as you present it, we face huge perforations, and sometimes the membrane is completely gone. And as you mentioned, the optimal approach may be the Loma Linda pouch, to use a large membrane, fix it all around, and put the graft material there. So my question is this. If we have two options, one, going with the big membrane and try to repair the perforation, the huge one, or abort the procedure and wait, which one do you prefer? Do you prefer to do the grafting in the time of huge perforations and almost no membrane available, or you prefer to wait and come back in next month?
Well, if you ask me personally, I can tell you that in all my entire professional career, I never aborted a single procedure. Mm-hmm. So I always, if I do have perforation, I always go and fix the perforation and place the graft material. Now, if you don't have a lot of experience, then I would recommend you, especially if you are a beginner, to do it in stages. But you have to understand that when you do have a big perforation, usually the quality of the Schneiderian membrane is such that it is very, very thin. So most likely it might tear up again. Mm-hmm. So I advise you to try and do it at the same time.
At the same time. And one of the other things is that sometimes the sinus is very big, both mesiodistally and mediolaterally. And when you want to try to close that huge perforation with tags and pin and the pouch technique, sometimes you cannot make sure the end of the membrane inside the sinus be completely immobile and fixed. So do you recommend putting the tags or pins inside the sinus or not?
No, I don't like to tack pins inside because, you know, sometimes if it's not really that fixated, it might shift. It's also technically not that easy. What I do prefer, if you are not sure that the membrane stays exactly where it is, to place, and I always place a superficial layer of PRF, and that will contain the graft, at least initially, and that's what we need.
I got it. So you don't prefer to put the tags because of the risks, right?
Yeah.
And about
the more you start to do all kinds of manipulations inside, you are elevating the potential problems of getting infection, and no matter how sterile you are trying to be, always there is a potential that you will get a problem.
yeah, and about the cases of implant migrations. Sometimes implants, when they migrate into the sinus, they stays in the apical part or around the middle. Sometimes they go up close to the floor of the orbit. So if such case happens, do you prefer to put the patient on follow-up, or you immediately ask the patient to go to the endoscopy and bring that out?
Well, I don't like patients going with floating implants because it might cause chronic sinusitis. Well, sometimes, there are patients that come to you and suddenly you see an implant floating in the sinus and the patient doesn't even know that he has an implant. But medical legally, of course, if that happens to you, you have to get rid of it. You have to take it out. Now, I found it quite easy to take those implants, no matter where they are, if you have a very good, powerful suction unit. And you use a small tip, eventually you will get it. And also lay the patient down because gravity is your help here.
Yeah.
So, yeah. Well, unfortunately, you cannot use magnetic appliances because the titanium is not really magnetic. So,
Yeah, I got it. And about the oroantral fistula, sometimes the inflamed tissue and that epithelialized channel through the sinus is very large. So in the cases of treatment of oroantral fistula, do you prefer to go inside the sinus and completely, evacuating all the membranes and the inflamed tissue available inside the sinus and do the like Loma Linda pouch to build up that sinus environment, or you only go for the apical part and doesn't include the thickened membrane on top?
well, it all depends how much infection you have in that particular case. If you just have a oroantral fistula after the surgery and there is no infection, you don't need to get rid of all the Schneiderian membrane. Because remember that the Schneiderian membrane also have an osteogenic potential and stem cells. And some of the bone, which is formed in the sinus, also comes from the Schneiderian membrane. But if you have chronic inflammation and pus coming out, you have to clean all the surface and get to some exposed clean walls. Otherwise, you will not be able to close it.
I got it. I got it. Well, Ziv, I wanted to just use the most from this time talking with you because one of the two experts and true educators in the field, especially in the field of sinus, is you. And it was so great talking to you and listening to you. And thank you for your time to answering all these questions. Again, it was a true pleasure for me, and I'm pretty sure for the audience, to joining you during this time with this amazing lecture. And appreciate it again. Hats off, and thank you so much for your for accepting this invitation.
Well, thank you so much for the invitation, and I wish all my friends, wherever you are, to be safe, and I hope we could meet each other as soon as possible.
Thank you so much, my friend.